His outcome will be good. But when he goes on ventilator, the mortality shoots up. So this is a high flow nasal cannula device. This is a schematic diagram where on the left side you can see the flow meter where it is connected to a high pressure oxygen source. So this is different from a regular nasal cannula because of two things. One, it has got the capacity to deliver oxygen at a very high flow rate, and it is humidified. At the same time, it is heated up. So in a regular nasal cannula, it delivers, although some humidified oxygen, but it is not at a very high rate. We get rates of maximum up to the flow meters up to 10 to 15 liters. But here we can deliver oxygen flow rates which matches the peak inspiratory flow rate of the patient. The patients are tachypnic, so the oxygen has to go the same rate because the peak inspiratory flow rate is very high. So patients require high flow rate oxygen, which is humidified and heated up. Because when you start inhaling oxygen, dry oxygen, which is not humidified, which is cold, coming at such fast rate, you develop a lot of dryness of the nasal passages, the throat. That is very discomforting. So this device, what it does is, apart from giving oxygen at a high rate, it humidifies it and heats up to the temperature set. We can set whatever convenient to the temperature which is convenient to the patient. Sometimes setting temperature 37 degree centigrade, the patient feels it's quite hot. So somewhere around 28 to 29 is a good temperature option for the patient to be comfortable on hyponasal cannula. So this is an NIV, that is a non-invasive ventilator device, which we very commonly use because this is easily available because most of the ventilators, ICU ventilators, have this option of NIV, where we can deliver the required fraction of inspired oxygenation with a mask. So what the patient is wearing is an interface device. There are various types of interface device. This is an example of a oronasal interface, NIV mask. So we have full face mask, we have only nasal mask, we have a helmet as well. So, but as we have seen clinically, this is the most comfortable and most tolerated interface. So here, so when we compare HFNC and NIV, the data says that for an acute hypoxemic respiratory failure like a COVID-19 pneumonia, definitely HFNC scores much over NIV. But NIV available, HFNC availability, and because oxygen is a scarce resource, because it's use of a lot of oxygen, we use oxygen up to 10 to 40 to 50 liters per minute. So the problem with HFNC is it uses a lot of oxygen, and if you don't have sufficient reserves, suppose you have a COVID care center with about 80 to 100 patients and you have about 30 intensive care beds, and if you have 12 machines of HFNC running at a time, your oxygen resources will get over very fast. That's the biggest disadvantage with HFNC. Whereas NIV is a modestly consuming oxygen device, so where the consumption of oxygen is not as high as HFNC, and it has got definite a role in patients with COPD, in patients coming with associated cardiac pulmonary edema, in patients with respiratory failure and exhaustion, because HFNC only gives flow. This, along with oxygenation, it gives pressure support as well, which will help in an exhausted COPD patient or a patient who is obese with obstructive sleep apnea component. These are the differentiation where NIV scores over high flow nasal cannula. So suppose we have a patient who is acutely hypoxemic. We have tried the nasal prongs, it's not working. We have just switched over to non-rebreather mask, it is also not working. Then any of your non-invasive options like HFNC and NAV are not working. So the only option left is go for intubation and mechanical ventilation. So I would like to reiterate the point once again that many a times initially when the data came, it was suggested that patients should be we should go for early intubation and mechanical ventilation. But as the mortality on ventilator was very high and the resource of mechanical ventilator as such is very much in shortage. So there have been guidelines which suggest that to delay intubation, not to a point that to put the patient's life in danger, but to give sufficient trial with your non-invasive devices like your HFNC or non-invasive ventilator, and only if the patient is going down rapidly on NIV, that becomes the indication for intubation. See, as you can see in the slide, the patient is in acutely respiratory distress with accelerated muscles of breathing, a rapid progression of disease, saturation is less than 19 despite maximal support, pH is dropping, PCO2 is rising up, and high flow requirement on HFNC, and obviously any hemodynamic instability and multi-organ failure patient requires mechanical ventilator. Now, once again, the same things, timing to intubate. One thing you have to remember, though, you have, when your patients you have on NIV who are acutely hypoxemic, there's something called happy hypoxemia, what we observe in these patients. Even though the patient saturation is 70, sometimes 65 to 70, clinically what we see, the patients are quite comfortable talking on NIV mask. But what happens is we have to keep a close watch. Unless you just keep a close watch, the moment you turn your head, suddenly they can collapse. So you have to be very cautious, not allow them to be hypoxemic to the point of exhaustion and having a cardiac arrest. So you have to be very cautiously decide, and the timing is very important, because at one side you have a scarcity of ventilators and which you have to selectively use at one point, and one side on the other side you have patients who are acutely hypoxemic, and you have to triage appropriately to use the scarcely available resources at the appropriate time. So this is the intubation procedure which is being done, which you all should know. You can see both the performer and the assistant are wearing adequate personal protective equipment with gloves and face shield, because intubation is an aerosol generating procedure. The patient is not adequately sedated, the patient coughs, then there's a lot of aerosol generation and is going to infect a lot of staff. So adequate precautions are very much necessary. So it is suggested that ideally a video laryngoscopy to be used to maintain a sufficient distance, because when we are not using a video laryngoscope, when we are using a regular direct laryngoscope, we go very close to the patient we are intubating. So that carries an additional risk of exposure to the healthcare worker. So this is an intubation box which came with a lot of promises initially. Even in our hospital, we had these 3 boxes ordered during the initial phases, but we tried to use it. But the problem here is when the patient is acutely hypoxemic, we have very less time to intubate and secure the airway. And these devices come with their own disadvantages. That is, when an easy intubation can become difficult because the maneuvering is difficult, because you have to put your hands to the holes provided in the box, where you might not be able to secure the airway on time, and patients can go down drastically. So because of that disadvantage, they have become less popular, and I think nobody uses them now. So we use a common term called as rapid sequence intubation or rapid sequence induction. So a patient who is acutely hypoxic, there is no time. Patient saturation is are dropping. So if you don't intubate them, the patients will have a cardiac arrest. So to prevent such dangerous hypoxemia, and you follow what is called as the rapid sequence induction, so which consists of 7 Ps, especially those of you interns working in the intensive care unit, you'll be aware that it consists of proper preparation, like before intubation, all equipment should be ready, a working laryngoscope, adequate tubes, and intubating guides like skillet, everything. Then we pre-oxygenate the patient, then pre-intubation optimization like starting an IV line and rushing fluids to prevent hypotension at the time of induction. And protection of staff and patient is very, very important. Adequate PPE should be worn by the performer, the assistant, and the staff assisting them. They should wear a face shield and gloves, which are mandatory. So we use succinylcholine or ocuronium for paralysis with induction, agents like midazolam or fentanyl for induction. And once the placement of tube is confirmed with ETCO2, we connect it to the ventilator for post-intubation management. So remember, these are the 7 Ps of rapid sequence induction. So once rapid sequence intubation is done, so we have to connect the patient to a ventilator. So it will be a little high level for you because management of ventilator in an ARDS patient is a topic in itself. So it requires a separate lecture. But for you to understand, what I want you to remember is ventilator management in an ARDS patient is low tidal volume ventilation. So traditionally, for a regular patient, we used to use a tidal volume of 10 ml per kg. But an ARDS ventilation, it is low tidal volume ventilation where we use tidal volumes from 4 to 8 ml, an average of 6 ml per kg. So we have a lot of parameters to monitor like positive and expiratory pressure, respiratory rate, fraction of inspired oxygen. These are the knobs which we play with and try to give the adequate oxygenation to the patient with the minimum fraction inspired oxygen concentration. Because the higher the oxygen, so once again, more toxic it is. So the minimal FiO2 adequating for adequate oxygen targets. So there's something called as the PEEP table, where FiO2 and PEEP we calculate depending on the various ranges. So this is usually by the intensivist. This is used where a higher FiO2 requires a higher PEEP. So basically, you have to remember two things here. In an ARDS in COVID, so we have two types of pathologies. Initially, the lung, when the initial stage of ARDS, it is called as the L type, where the lung elastance is low and high compliance. So subsequently, as the disease progresses, they go for H type, where the elastance is high, but the compliance is very low. So the patients who go to H type are those who require high PEEP and recruitment. I'll tell you what recruitment is. Now, you have intubated the patient and put the patient on ventilator, and but still, in spite of your adequate fraction of inspired oxygen, you have given positive and expiratory pressure, and you have done recruitment. Recruitment is nothing but giving high PEEP to open up the collapse alveoli so that the oxygenation improves. So in spite of adequate recruitment, your saturation is not picking up to your targets. So what is advised is something called as a prone ventilation. As Yunus was talking about awake proning. Awake proning is done in mild to moderate cases where the patient is awake and he can lie down prone himself with an oxygen mask or whatever device he's on. Here, prone ventilation is done for an intubated and a sedated and paralyzed patient who's on an endotracheal tube, and which is done because to improve his oxygenation. So as you can see, the patient will be in this position. Patient is intubated. This is a very difficult position to lie down. It's very painful. So the patient is under sedation and analgesia. So you have a lot of pressure points over there. So we just take care of the eyes, the nose, lips, chest, genitalia, then the knees, so which can get compressed. So we have to place adequate pads so as to release the pressure on these pressure points. So usually the proning is done for about 16 to 18 hours per day. So this will improve the oxygenation. This is one of the methods by which a patient on ventilator, if is not maintaining adequate oxygenation, is done prone to improve his oxygenation levels. So there was a study called as Persever trial, which showed a mortality benefit with proning in ARDS patient. So that has been applied to COVID-19 ARDS as well. So we see a lot of ICUs with severe ARDS patient who do proning. So in spite of your proning, the oxygenation targets are not being met, then you have, as I already talked about, recruitment manuals, high P. Then you have certain things called as pulmonary vasodilators like nitric oxide or prostaglandins, which they used to improve the pulmonary vasodilatation and to prevent hypoxic pulmonary vasoconstriction. So as a result, the oxygenation improves. That's a theoretical aspect, but we don't have availability of inhaled nitric oxide in India. So we don't use it in our setup. Neuromuscular blockade, because patients will be paralyzed completely, to reduce the chest wall compliance and to allow better expansion of lungs. And as a last resort, ECMO. There is extracorporeal membrane oxygenation can be used, but it is not universally available. So contraindications to proning, I'll not go into much details, but I want you to know what are the complications of prone ventilation. So a lot of, as I said, because it's a very difficult position to lie down, so you have no compression, then crush injury because the muscle crushes there, venous stasis. Dislodgement of endotracheal is a very, very dangerous complication. The patient who is in prone position, the tube comes out, then they put it again supine and put a tube again. So dangerously, the oxygen levels are going to drop down and patients are going to be in cardiac arrest. So you have to be very careful. So this prone ventilation is a staff intensive, stressful, intensely stressful for staff as well. So when your intensive care unit is not adequately staffed with trained nurses, so it's always dangerous to prone patients in such ICUs. So you should have adequate quality staff who are experienced in proning patients, only then it will work. So one thing which I want you to remember is pregnancy is a contraindication for prone ventilation. Similarly, patients coming in shock, actively bleeding are contraindications. So we'll skip this. So now coming to ECMO. So there's a lot of hue and cry about extracorporeal membrane oxygenation. Even WHO has suggested ECMO as a rescue therapy. So you have patients with severe ARDS who are not improving on ventilator, who are not improving on prone ventilation, and you want to do something additional. So ECMO is an option provided the patient can afford it, and provided the required infrastructure is present in the institute, because it is not universally available in all the hospitals. In Bangalore itself, only selected about 3 or 4 hospitals do ECMO. So the problem is the cost factor and availability. So this is a schematic diagram of ECMO. What is it all about? See, extracorporeal membrane oxygenation it's not a new thing. It has been used in cardiac OTs. So when the patient goes for heart surgery, when they stop the heart, so the heart-lung machine takes over. So it takes care of the circulation and oxygenation. So here, this is an example of a veno-venous ECMO, where the blood is drawn from the femoral artery. You can see the arrows there, and it goes to a pump, and then it goes to the oxygenator, which oxygenates the blood, and it is returned to the venous system. So it is returned to the superior vena cava, from the femoral vein to the superior vena cava. It is veno-venous ECMO. This is what is commonly used in COVID patient or any ARDS patient. So there is one more thing called as veno-artery. So this veno-venous, which is an option for COVID-19 eligible adult with ARDS. So there's something called veno-arterial system, where the blood is drawn from the veins and it is pushed back into the arterial system, like the aorta, where it gives an additional support for a failing heart. So Veno arterial ECMO is used for patients with ARDS with associated cardiac conditions like cardiomyopathy, severe heart failure, RA dysfunction. So in only such cases, we know. Otherwise, if somebody asks you which is the most common type of ECMO which is being used, it is a veno-venous ECMO. So once again, see, we don't want to put a moribund patient who is elderly with multiple organ involvement on an ECMO and waste the resource and money on that. So one has to be very selective. If a young patient is there who is fighting on ventilator, it's really worth, if the patient can afford, it's really worth trying for an ECMO. But these are the contraindications are like multi-organ failure, advanced malignancy, definitely, because you're not going to make any much difference by giving putting them on ECMO for a long time, because patients when once they go on ECMO, they take 1 week, 10 days, 2 weeks to come out of ECMO. If it is a really young patient without complications, they do come out. So related. So heart failure, all these are cardiomyopathies are the related contraindications. Now, after ECMO, um, what are the CPR in COVID? What you should know about CPR in COVID? So you have done everything possible, but still patient develops a cardiac arrest. So how it is different from regular CPR? Because CPR, once again, you come very close to the patient to give a lot of chest compression. There is airway management, so there's a lot of aerosol generation. So in the event of the cardiac arrest, CPR should proceed with all members of the team wearing appropriate PPE. So the staff and the doctor should be well protected. So always better to practice test run of CPR. Like how are you going to do it? And you have to run a scenario like who's going to do what. So in case of a cardiac arrest, that's what we normally do, and we train our nurses and doctors for CPR in any event of cardiac arrest. So bag mask ventilation should be avoided because it causes a lot of aerosol generation. If possible, only it should be used with a filter. Otherwise, directly intubate and put the patient on ventilator while doing CPR. So these are the American Heart Association guidelines for basic life support, especially whenever you witness a cardiac arrest. So you call for help, then you protect yourself, you put a mask on the patient, then you do hands-only CPR. There is no mouth-to-mouth breathing, no airway management, only hands-only CPR till the help arrives, and until then you use an automated external defibrillator, AED. So this is how you give CPR. Like you can see, the healthcare worker is appropriately protected by goggles, face shield, and full PPE. Okay, apart from respiratory support, intensive care is all about supporting other organs as well. We see a lot of patients in renal failure because there will be sepsis, acute kidney injury, and a lot of drugs also cause renal failure. And the one thing which I want to mention about the most commonly used drug for COVID-19, remdesivir. Though remdesivir per se is not nephrotoxic, but it comes with a cyclodextrin molecule, which is supposed to be nephrotoxic. So in patient with creatinine clearance less than 30, it is definitely not a wise decision to use these drugs. And we have patients with cardiac failure as well, because hypoxemia, again, patient with pre-existing ischemic heart disease, it is worsening of ischemic heart disease per se, and there is some amount of myocarditis because of COVID virus per se, and also patient do present with a lot of arrhythmias, and the patient presents with MI. One of the common mode of presentation to the ICU, we have seen quite a few young patients in their 30s and 40s present with acute MI, primarily as MI, then being diagnosed as COVID-19. So we have seen young patient coming with stroke primarily, because as we were discussing, as Dr. Yunus was discussing, COVID infection gives rise to a hypercoagulated state. So there are a lot of thromboembolic complications everywhere. So you have a patient with stroke, you have patient with myocardial infarction, you have patients with DVT, and you have patient with acute limb ischemia. We had one young patient who came present with full gangrene of the whole limb because of his whole femoral artery was thrombosed because of COVID. So we do get a lot of encephalopathies, which is because of hypoxic, metabolic, and because of stroke per se. So apart from the respiratory care, intensive care is all about giving organs support to the organs which fail. So then, uh, not to be taken very lightly, supportive care, because as we have seen, a lot of evidence has shown that nothing is working. The recent, till yesterday or day before, I used to believe that only two things work in the ICU, that is steroids and remdesivir. But after the results of the famous WHO Solidarity trial came, even I have lost hopes on remdesivir. So, but what works is a very good intensive care with good oxygenation support, steroid cover, with good nutrition, stress ulcer, DVT prophylaxis, taking care of the back of the patient because they'll be lying down long for a very long time. They'll develop bed sores, back care, and adequate physiotherapy because they'll have a lot of critical illness, neuropathies, myopathies, and as a question came, like steroids in diabetics. Definitely, we do use steroids in diabetics, but that will cause sugars to go high. But it has to be intensively controlled. That is the only option. Glycemic control. Otherwise, you'll end up patient with sepsis and other complications. So now, very important thing in the end, what I would like to stress is COVID-specific treatment. As I was telling you, steroids are possibly the game changers. Only thing which evidence has shown to be, which is very useful, is steroid, like 4 randomized control trials and meta-analysis of a robust evidence that steroid administration in COVID-19 patient with acute hypoxemic failure has improved mortality, ventilator-free days. So recovery trial has used dexamethasone 6 milligram. We can use any other steroid like methamphetamine of equivalent doses. So coming to antivirals, so remdesivir administration may shorten the duration of illness. However, its impact on mortality and efficacy in severe illness patients remain unclear. This was before the Solidarity trial, but Solidarity trial has proven that remdesivir has got no effect on mortality. Convalescent plasma. We do use a lot of plasma in patients. So they say if donors have got good titers of antibodies, definitely it's going to help in the initial stages. But once again, the evidence of a solid change of the treatment scenario is lacking. So we just give because there is mixed evidence and we have to do something. Coming to IL-6 inhibitors, so there is a lot of hue and cry once again because each injection of tocilizumab costs about 40,000 rupees. It replaces a lot of cost burden on the patient. So, but having said that, we do use tocilizumab because to prevent the inflammatory response. But does it have any positive impact? It's very difficult to say because evidence is lacking and is not shown to be of any benefit. So, but a lot of subjective, if you ask a lot of doctors, they say they feel that it works, but it has not been documented. There is no evidence, proper evidence. So I don't know, but there is a lot of adverse effect like infection. So do we have to use an expensive drug which has got a lot of side effects only because we believe it will work? So it's really not a good idea. So I'll leave you there. So coming to other aspects of treatment like anticoagulation, because to prevent DVT, definitely we use anticoagulation. Sometimes in mild cases, prophylactic, whereas in ICU admitted patients, therapeutic doses being given. Coming to antibiotics, so it depends on the institution, hospital antibiogram and hospital policy, but it is not a blanket treatment to give antibiotics for each and every case being admitted to the hospital. So only in proven secondary bacterial infection, antibiotics are advisable, otherwise not as a routine. So to summarize, critical care in COVID deserves multidisciplinary approach. It's not only intubation, mechanical ventilation, and put the patient on lines. You have to give a multidisciplinary organ support. You have to involve most of the specialists and take care of the patient extensively in a multidisciplinary approach. So you have to maintain the oxygen target at the same time by hook or crook. Either you put them on HFNC or NIV or prone ventilation. ECMO is an option for the privileged evidence-based approach in specific therapies. So because everyone is using, don't fall for new drugs and expensive drugs unless an evidence dictates it. Don't use it. That's my approach. So adequate organ support and prevent complications. So there's a definite role for giving organ support and preventing complication. That's where you can make a difference. So as we have seen, nothing much works except for a good supportive care, maintaining good oxygen targets and steroids. And having said that, last not the least, a good nutrition with rehabilitation will help a long way in giving a positive impact on the health of these COVID-19 patients. So with this, I'll end this topic. Thank you so much for kind listening and concentration. I welcome any doubts.
There is a space for interactive section where the attendees can ask their questions and clear the doubts.
Please raise the hands. I will allow you to ask questions, or just put the questions in the chat box. So I believe there is no questions from the audience for the intensive care medicine. Sir has explained the in-depth and whatever is required for the graduate, undergraduate level and post-graduation PG. So, sir, thank you for joining us, sir. Thank you for your time.
Thank
So
you.
that was Dr. Zahid Ahmed, sir, critical care physician, and he was speaking about intensive care and COVID. He had covered about risk factors, oxygenation targets, low and high flow systems, oxygen delivery devices, use of HFNC and NIV, indications of intubation, timing to intubate, RSI, titration of PEP, prone ventilation, additional rescue therapies, complications, contraindications, ECMO, veno-venous and veno-arterial, CPR in COVID, organ failure support, supportive care, COVID-specific treatment. Thank you, sir. Thank you so much. This is all about our CME for today. And now I welcome Abu Huraira for the felicitation.
So, good afternoon, everyone. I'm Abu Huraira. So today's session we had microbiology. Starting with microbiology, we had community medicine, preventive aspects, followed by the pulmonological aspects, and at last we had an intensive care session. So today's session, whatever we had planned was completed as of smoothly, I hope, and I hope you have all. It will be useful for you in the coming days. So coming to the thanking and felicitation part, there are a lot of people involved to set up this CME, and it is a first of kind of virtual CME for undergraduates, targeted undergraduates on the COVID-19, and I'm happy that it went smooth. So I will first of all I will thank all the speakers, Dr. Nasir sir, microbiology, Farah ma'am, community medicine, St. John's Medical College, Dr. Yunus sir, pulmonology, and Dr. Zaid sir, intensive care. Thank you, sir. Thank you all the faculty for the time and for the information what you have provided. And I want to thank Dr. Sadiq Sharif sir, who is a cardiothoracic surgeon, who had helped a lot for setting up this CME. Before ending up the session and winding up the session, I like to call Dr. Sadiq Sharif sir for a small pep talk, after which I will be just briefing or giving an umbrella view of what we have planned for a second session, which is scheduled on 25th October. Over to you, Sadiq Sharif sir. Sir, please unmute yourself, sir. Am I audible?
Yeah. Am I audible now?
Yes, sir. Yes, sir.
Yeah. Good afternoon, everybody. It's very heartening to see all of you on a Sunday morning gathering for this talk. Uh, I'm just in between some program with some patients, so I would not take much time. Of course, it's a very great initiative by the undergraduate students. Which you have taken up, because COVID-19 is going to be a threadbare exam, and other discussion oriented topics will revolve around COVID for the next coming 3-4 years at least, whether it's your entrances or your college exams. It's going to be a hot topic. I congratulate the team once again, and I'm looking forward to the next Sunday program. And this is how you have to step up in your career also. You know, medical profession is to help wherever possible, whether your colleagues, your patients, everywhere. See, one small group of students has come forward, and it has helped so many students. I think at least around 200 students are attending this program. So this is the main essence of our profession. We should be looking to help wherever we can, and looking forward to collaborate with Medlight for further programs also. The next Sunday's program, Abu Huraira, you can brief them, and as soon as the timings are confirmed, I think the flyers can be sent out.
Yes, sir. Thank you, sir. Thank you for your support and thank you for joining us.
Yeah, most welcome.
So coming to the second session, what we have planned a second session based upon the medicine part, which is the most important aspect as per COVID. And we have a surgical protocol session, and we have the OBG, that is maternity in COVID. And these all the topics will be taken up by the one of the most famous and most knowledgeable people we have got. I will be sharing the posters along in the group. So what I request you is, we had got a registrations of around 400 plus, and we had sent email for everyone. There are many people who haven't joined our WhatsApp group. All the notifications on the related to CME will be just posted in the group. Please join the WhatsApp group. If in case you have not been added to the group, I will leave the number here. You can just WhatsApp it, and you will get the link. And I thank all the people who have joined in today and make the event successful. So the event which is scheduled on 25th is medicine, surgery protocols, maternity in COVID, and we are planning to include pediatrics also. I will keep you updated in the group. So thank you everyone. Thank you for joining. I hope it will be useful, and the feedback form will be given up in the WhatsApp group. And please let us know how it was, and please suggest us how we can improve. Thank you everyone. John, can you wind up?
Yes, thank you, Abu. Thank you so much. So Abu has detailed about what will happen on next Sunday, that is 25th. And I request all the attendees to attend on 25th, because the e-certificates will only be delivered if the attendance is fulfilled on both the days of, that is day 1 and day 2 of the CME. Thank you all who have attended. Thank you so much. Have a great afternoon.